Hello, and welcome to the webinar on fatty liver disease. We are happy to have you with us for this informative webinar. Today, June 12th, is Global Fatty Liver Day. The silent disease has been on the move around the world for many years. I am Farah Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us. Liver Health Foundation is a patient advocacy 501c3 nonprofit agency representing millions of liver patients in California and beyond, with the mission to support liver patients, their caregivers, and family members. We operate in Los Angeles, Inland Empire, Orange County, San Gabriel Valley, San Fernando Valley, Palm Springs, and all neighboring cities and counties. As I mentioned before, tonight's webinar is about fatty liver disease, also known as MASLD and MASH. Global Fatty Liver Day was established in June 2018 to enhance awareness and to emphasize the pressing nature of fatty liver disease, particularly its advanced stages, which impacts more than 115 million individuals worldwide. It is estimated that by the year 2030, 357 million people will be affected by fatty liver disease. Because symptoms of fatty liver disease are often not obvious, this disease is often underdiagnosed and underreported. Untreated fatty liver disease may lead to cirrhosis, liver cancer, and liver transplant. In the United States, greater than 70% of people with type 2 diabetes have hepatic steatosis, and many have MASH, which is the more severe form of MASLD. Having MASH carries a significant risk of future cirrhosis, especially in the presence of obesity and type 2 diabetes. And it even increases the risk of developing liver cancer. It is believed that cirrhosis from MASH will be soon the most common cause of liver transplantation in the United States. It is against this background that we embark on tonight's journey to learn more about fatty liver disease and understand guidelines for screening, diagnosis, treatments, and monitoring. Please remember, information given by our experts is not a substitute for advice given by your own physician or healthcare provider. This program has been made possible by an educational grant from Madrigal Pharmaceuticals. We thank Madrigal for their support and their commitment to raising awareness of fatty liver disease. In tonight's program, we are honored to have some of the best hepatologists with us. It is my pleasure to introduce Dr. Bishu Yanni, who generously has accepted to be the presenter for tonight's program. Dr. Yanni is Program Leader, Hepatology, UCLA Medical Center, Santa Monica, Health Sciences Assistant Professor of Clinical Medicine, Bauchi and Tamar Manukian Division of Digestive Diseases, David Geffen School of Medicine at UCLA. Dr. Yanni specializes in general and transplant hepatology and focuses on treating patients with a wide spectrum of liver disorders. He is well-versed in the treatment of hepatitis C with the new direct-acting antiviral agents. He cares for patients with liver cirrhosis and is a spectrum of complications. He also cares for patients before and after liver transplantation. His research interests include non-alcoholic steatohepatitis, hepatocellular carcinoma, and viral hepatitis B and C. Dr. Yanni has presented research at multiple national and international societies, including AASLD, EASL, Guild, and DDW. We are proud that Dr. Yanni is a member of the Liver Health Foundation's Medical Advisory Council. Dr. Yani, thank you for your support and participation. We are ready for your presentation.
Thank you very much, Farah, and for the very nice introduction. And thank you and welcome everyone to this talk today. Let me go ahead and share the slides. Okay, so hopefully everyone can see the slides now. So today we're going to be talking about metabolic associated steatotic liver disease, or MASLD, or hepatitis, MASH, previously named MASLD-MASH. So what is fatty liver? Fatty liver, architecturally or big picture is when the liver turns from looking nice and normal, as you can see to the left of the screen, to accumulating fat, and you can see that the structure differs a little bit, and the color and texture at the level of the organ itself also changes a little bit. And it's defined as evidence of finding hepatic steatosis, which is also called fat in the liver, either by imaging or by tissue biopsy. It is important to exclude all other causes of fatty liver accumulation, such as significant alcohol consumption, such as long-term use of certain medications that can cause fat accumulation, such as some hereditary disorders like Wilson's disease, alpha antitrypsin disease, and other steatosis accumulating liver diseases. So the difference between metabolic dysfunction associated steatotic liver disease and steatohepatitis is the presence of inflammation in the liver. So MASLD is defined by the presence of 5% or more steatosis on histology without the presence of ballooning and inflammation. And MASH, there is ballooning and inflammation noted under the microscope. What does that mean? So, if you can imagine with me, the liver cell looks like a square rectangular type of shape. When you look at it under the microscope, when the liver cells become fatty, the fat kind of takes over the corners, and the liver looks like a sphere or a balloon. So because we're very creative in medicine, we call that ballooning. And then when the liver cell accumulates more fat, the fat actually breaks the liver cell, and the stuff that's inside the liver cell comes out. And the stuff that's inside the liver cell is called transaminases, or there are certain enzymes that live in the liver cell. Once they spill out in the bloodstream, we can detect them. And when they go up, that is a marker of inflammation of the liver cells. And that's called steatohepatitis, or inflammation of the liver cells secondary to the fat accumulation. Is fatty liver relevant? I think Farah actually covered this very well. Fatty liver is very relevant. It is becoming a leading cause of end-stage liver disease, requiring liver transplantation in the United States. And it is a major cause of cancer in industrialized countries. In the US, studies report a prevalence of MASLD of 10 to 46% in the US population, with most studies reporting MASH in about 5 to 15% of those patients. Worldwide, MASLD has been reported at a prevalence of approximately 6 to 35%, with a median of 20%. As you can see, these numbers have a very wide range, and the reason there's a wide range is because, every country reports MASH in their population, and there isn't really a good number for that combines all those countries together. So there's a wide range there. In this context, most patients who have obesity and are undergoing bariatric surgery are noted to have MASLD during the bariatric surgery. And in fact, sometimes it's not uncommon for the bariatric surgeon to take a biopsy of the liver to look at the severity of the damage of the liver. Many patients with type 2 diabetes have MASLD and MASH. And some studies suggest that up to 2/3 of patients with diabetes have MASH, have MASLD. It is thought that epidemiologic studies underestimate the real incidence and prevalence of fatty liver, as the gold standard for the diagnosis is a liver biopsy. And unfortunately, up to recently, until awareness is becoming more and more in the medical community, many patients were not screened because there were not any screening guidelines for those patients. Well, why is it important? If fatty liver left alone without any treatment, patients will develop liver fibrosis, and liver fibrosis can lead to liver cirrhosis and liver cancers. So in that process we talked about earlier with fatty liver disease, if the steatosis and inflammation of the liver happens over and over again, then the liver can regenerate to a certain extent until it can't anymore. For an example, this is not exactly what happens in the liver, but very similar. If someone hurts their hand, get a paper cut in one area, the first few times it's going to heal up. The tissue will go back to normal again. The hair follicles will come back. The sweat glands will come back, and the area that was cut will look normal again, and it will function normally. As you do that over and over again to the same area, it will turn into scar tissue, and it will look different, and it won't function the way it's supposed to, as a protective layer in the skin example. So when a bug goes on the skin, then it might not feel it anymore, or when that area gets injured, it might not feel it anymore because it's not functioning as regular skin anymore. So a similar process happens in the liver. When the inflammation happens over and over again, scar tissue starts accumulating, and that's called fibrosis. Fibrosis is a stage between 0 and 4. Once patients get to fibrosis 2 to 3, there is 33% of patients will unfortunately progress to cirrhosis within 2 years, and within 4 years may require a liver transplant. In the US, MASH is the leading cause for liver transplant in women, and MASH-related cirrhosis is becoming the leading cause in liver transplantation, plus alcohol. Year after year, the MASH goes up in terms of placing patients on the liver transplant list. Patients with non-cirrhotic MASH with fibrosis have a 3 times increase of risk of liver cancer, or what's called hepatocellular carcinoma, over those with other disease etiologies. So what are risk factors for fatty liver, and what are some of the preventative measures? So some of the risk factors for fatty liver are metabolic syndrome, and metabolic syndrome is a syndrome that patients have multiple metabolic risk factors such as diabetes, high blood pressure, high cholesterol, insulin resistance. Some of the other non-metabolic related issues are hypothyroidism, obstructive sleep apnea, hypopituitarism, hypogonadism, and insulin resistance is also part of the metabolic risk factors there, and polycystic ovarian syndrome. So patients who have these risk factors, it may be worthwhile to screen for fatty liver. Well, how do we diagnose patients and how do we link them to care? So diagnosis is by demonstrating hepatic steatosis or fat in the liver by imaging or biopsy, exclude significant alcohol consumption. And that is, depending on which guideline you read, significant alcohol consumption is 7 drinks, standard drinks per week for women, and up to 9 drinks for men, or 14 grams of crude alcohol for women, and up to 28 grams of crude alcohol for men. Exclusion per night, that is. Exclusion of other causes of hepatic steatosis, such as medications that can cause fatty liver. Some of those are hormone replacement therapy. Some of them are blood pressure medications, among others like chemotherapies and whatnot. Absence of coexisting chronic liver disease such as viral hepatitis, genetic and metabolic diseases such as Wilson's disease, alpha-1 antitrypsin disease, and other that could make the liver look fatty without having the metabolic associated steatosis. So when a patient establishes care with the liver doctor, depending on the risk factors and depending on the clinical picture, a panel of tests are ordered to check for those things as part of the workup. The American Association of Study of Liver Disease recommends that patients that have one of these 5 criteria should probably be screened for fatty liver. And as you can see the criteria here, I won't bore you by reading every single one of them, but if there is a BMI of above 25 or a waist circumference of over 94 centimeters for men or 80 centimeters for women, impaired fasting glucose, blood pressure over 130 over 85, or patients being on antihypertensive medications, plasma triglyceride level of over 150 milligrams per deciliter, or HDL cholesterol of less than 40 for men and less than 50 for women, or patients who are on lipid-lowering agents. Well, how do we test for these patients medically? We test initial test that's recommended by the major societies is called the FIB-4 score or fibrosis 4 score. Fibrosis 4 score is a score that takes into consideration some of the liver blood tests, so called AST, and the platelet count and the patient's age, to tell us whether the patient is at high risk for developing or has high-grade fibrosis or not, and if further testing and treatment is needed and linkage to care is needed. Well, progression for fatty liver, as we talked about initially, with patients start with a normal liver, and fatty liver accumulates, and then scar tissue starts accumulating. So this is fatty liver with no fibrosis, just architectural changes. And this is fibrosis 1 to 2, then goes to fibrosis 2 to 3, then fibrosis 3 to 4, or 4 or initial stages of liver cirrhosis, and then liver cirrhosis and possibly development of liver cancer. This process can take many, many years to develop, and the progression of liver disease is very variable between patients, and the variability depends on many things. It depends on genetic factors, it depends on environmental factors, it depends on diet and availability of certain foods, it depends on consumption of alcohol, and starting out with a liver that may have not been very normal. So progression can take years, but it is very variable between individual patients. So once cirrhosis develops, the architectural look of the liver, or the way the liver looks, it becomes very nodular, as you can see to the right side of the screen there. And the longer cirrhosis stays, the longer complications may occur, such as esophageal varices and jaundice, and other things that can happen from complications of liver disease. So these are some of the most common complications of liver disease here. One of them is hepatic encephalopathy, or confusion secondary to liver cirrhosis. Hepatic encephalopathy happens when the liver can no longer clear toxins, and they cross the blood-brain barrier and cause confusion. Ascites, or swelling of the abdomen with water accumulation, jaundice, esophageal varices, or varicose veins that happen in the food pipe, or the tube that connects the mouth to the stomach, which can be very severe and dangerous, and development of liver cancer are all complications of liver cirrhosis. Is progression to liver cirrhosis imminent? No. If once diagnosed with fatty liver disease, lifestyle modifications and risk factors are modified, and treatment is initiated quickly, patients may be able to prevent or regress the progression of the disease here. So treatment for fatty liver is typically multidisciplinary between the gastroenterology hepatology doctor, between the primary doctor, the cardiovascular medicine, weight management, and obesity medicine if available, and psychiatric and mental health. So initial risk stratification, as we've talked about, would be the FIB-4 score, and once the FIB-4 score shows a number that's over 1.3, then it may be worthwhile to do more testing, and we'll typically link our patients to care with a specialty provider, such as a gastroenterology doctor or a hepatology doctor, to discuss how to move forward from there. Well, the number one treatment recommendation for patients with fatty liver or hepatic steatosis or NASH would be the MASH would be to work on lifestyle modifications, dieting, and controlling and bringing down the weight by about 10% of 10 to 12% of body weight in 6 months to a year, unless patients are already lean or do not have that much weight to lose. And in that case, we work more towards treating by modifying the diet alone and not really focusing on the weight loss per se. So in hepatology and New England Journal of Medicine, these two excellent groups put together this treatment algorithm by saying improve the caloric intake or decrease the caloric intake by approximately 30% kilocalories per day to improve insulin resistance and hepatic steatosis, limit consumption of fructose-enriched beverages. Weight loss goal of 3 to 5% can improve steatosis. 6 to 10% is needed to improve NASH and fibrosis. Exercise alone may reduce steatosis, but effects on histologic features, whether the fat really disappears from the liver or not, is not very well known, and it is recommended that not to drink alcohol in patients with fatty liver disease. And there are some small studies to show that to more than 2 cups of caffeinated coffee, if tolerated daily, may be helpful in patients with fatty liver. So that's the first step to try and control fatty liver. And one of the diets that has been studied by this group here, Anania and group, which was also published in the World Journal of Gastroenterology, is the Mediterranean diet. And I put this picture here because I kind of want to bring to our eyes what a 1,500 calorie Mediterranean diet looks like. As you can see here, it's not a lot of food, and many patients will go will feel the urge to have more food. It's very hard to go on a low calorie diet. We're not really not really minimizing that aspect. It's definitely very it's one of the harder aspects, but it's it's really needed to improve the steatosis and the fibrosis in the liver there. Treatment. What if diet and exercise don't work very well? Although that's the first line of therapy recommendation there, it's actually a very exciting time in liver disease because there are many new medications that are on the verge of coming up. But for now, the only FDA-approved medication for fatty liver is called resmetirom. It is considered for a select group of patients. It is a thyroid hormone receptor agonist. The thyroid hormone typically increases metabolism, improves breaking down of fats and sugars, and this group found that resmetirom, which is what's called the thyroid hormone beta receptor agonist, which is the beta receptor is very abundant in the liver and somewhat in the kidneys, will help improve fatty liver and fibrosis in about 25 to 30% of patients. This has been shown by a study that was done to get this accelerated approval at the FDA. However, disease stabilization has not been very well studied yet. There is some preliminary data that shows that actually using this medication can stabilize the disease, which is also considered a win, if no progression from fibrosis to and no movement towards cirrhosis. So it is recommended for a select group of patients. So discuss with your physician if you think you may benefit from this. There are non-FDA approved treatments that show some promise. I think many of us may be aware of this. As you have seen, they have come up in multiple TV shows and multiple commercials. They're the GLP-1 agonists or medications that have been helping with weight loss. One of them is called tirzepatide, the other one is called semaglutide. There is some very preliminary data that was presented at Digestive Disease Week and at the European Study of Liver Disease that these medications may be helpful to improve steatosis, steatohepatitis, and even fibrosis. However, these medications are still not FDA approved for fatty liver, may be used for other metabolic risk factors, and could possibly improve the liver as well. But I think we may see some more data that would help the FDA approve this for fatty liver in the future. Other treatments that are non-FDA approved that are kind of been studied over and over again and have been mentioned in multiple of the society and associations recommendations are vitamin E, which vitamin E was studied for patients who do not have diabetes, but it has some risks there, as you can see, that in patients who take more than 100 400 international units per day, may be at increased all-cause mortality risk. There's an increased hemorrhagic stroke risk and increased prostate carcinoma in men. These studies are very, very small, but they're there, so it's something to keep in the back of our minds when we discuss this with our patients, if there are no other options. But this was at the time when there were no FDA-approved medications. So now we have certain things that we can discuss and prescribe for our patients that can help with this process. Pioglitazone, again, these are some of the risk factors associated. Key considerations is to definitely improve on the risk factors, so improve lifestyle, improve on alcohol use by lifestyle interventions, consider statin use to help with lowering cholesterol, bariatric surgery when indicated if none of the medications are working and the patient continues to progress. And finally, if the patient unfortunately progresses and has liver cirrhosis and decompensation, can consider liver transplantation, evaluation for liver transplantation. Well, what if cirrhosis occurs? So if cirrhosis occurs, there will be expectant management takes place, and expectant management is with making sure that patients are vaccinated for hepatitis A and hepatitis B, not to use any alcohol, not to use any tobacco, and standard cirrhosis and cancer screening care. Patients have very variable prognosis and progression. Some can have compensated cirrhosis for many years, and some end up with decompensation and needing liver transplantation much sooner than others. So overall, once liver cirrhosis occurs or decompensation from liver cirrhosis, it would be a good idea to establish care with a gastroenterologist or hepatologist that is trained and comfortable to deal with this condition. So screening and follow-up, previously there was no guidance for routinely screening the general population for NASH. At this time, it's still not very solidified on society guidelines, but at least we have some on the horizon that show that patients who have certain risk factors such as obesity, such as diabetes, high blood pressure, high cholesterol, may benefit from screening and linkage to care early on. Some data supports screening patients with metabolic syndrome, as we talked about. Once NASH NAFLD is noted on imaging such as ultrasound, then discuss workup of fibrosis staging and scar tissue accumulation, which can be done in various ways. Some of the ways include blood testing, some include what's called transient elastography, some include MRIs, depending on the risk factors and the availability of those modalities to the doctor and the center you are in. If high-grade fibrosis or liver cirrhosis or liver cancer happens, then a patient should be linked to care at a liver transplant center. Liver cancer screening should commence, and patients with liver cirrhosis every 6 months. There is no data to support routine cancer screening for patients with MASH, MAFLD, without high-grade fibrosis, although we're also seeing that may be changing in the future. If stage 2 fibrosis or high risk present, consider referral to an initiation of care with a liver or GI specialist to consider some of these newer medications we talked about. And if cirrhosis and decompensation occurs and medications are not helpful in that situation, then consider liver transplantation. So treatment for decompensated liver cirrhosis is liver transplant. This is a picture of the first transplant that was performed at UCLA on February 1st, 1984. As you can see, this brings home the prevalence of fatty liver and how things have changed over the years. You can see that fatty liver has an increasing proportion on the pie of patients that need liver disease there, liver transplantation there year after year. This is 2008 versus 2022. You can see that it has almost doubled. And since 2022, this continues to increase, believe it or not. So in summary, lifestyle intervention and weight loss are the most important for patients with MASH MASLD. Fibrosis improvement requires longer term treatment and typically requires liver-specific targeted therapies. There are newly approved medications such as resmetirom to consider with your liver doctor. It is a very exciting time because some other medications are coming up, and we still are collecting data to see whether there is stabilization of liver disease with the recently approved FDA medication. Some medications may be available, as we talked about, and if high-grade fibrosis or cirrhosis develops, it is recommended to establish care with a liver doctor and a gastroenterology doctor that may be, well versed in this disease process and can help link patients to care in transplant centers if they need to. So thank you.
Thank you so much, Dr. Yanni. This was great. I appreciate that. And this is a disease that unfortunately a lot of people are worried about and are being diagnosed with. So let's hope that we gave this information helped them. So thank you very much for your presentation. Now we will start the second half of the webinar, the roundtable conversation with our guest experts who will talk about fatty liver disease and respond to your questions. Please remember you can enter your question or comment on the chat function or Q&A tab. I am honored to introduce Dr. Haider Jamal. Dr. Jamal is the Medical Director, Hepatology, SJMC, Associate Medical Director, Subspecialty, Providence St. Joseph Heritage Medical Group. Dr. Jamal is a general gastroenterologist with additional training and expertise in hepatology. With his team of nurse practitioners and dietitians, Dr. Jamal leads the liver clinic, which focuses on patients with complicated liver diseases that require more intensive management. This clinic has access to state-of-the-art imaging, interventional radiologists, oncologists, and hepatobiliary surgeons in order to provide truly comprehensive attention to their patients. The use of FibroScan enhances the clinic's accuracy for assessing damage to the liver with a liver biopsy. Dr. Jamal has a passion for teaching students, nurses, and physicians. He's focused on providing compassionate care as part of a team of excellent physicians, which is what keeps him glued to the St. Jude Heritage family. Dr. Jamal is an active member of the Liver Health Foundation's Medical Advisory Council. Dr. Jamal, welcome, and thank you for your participation.
Thank you, Burr.
Over the past few days, I've received questions from the audience and those who couldn't be with us tonight. I've submitted the question to our presenters to review and respond. However, as I mentioned, the audience can also put in their questions. To start the roundtable, I would like to pose a question that was repeated several times as our audience sent their questions in. The question is, how to ensure timely diagnosis and patient awareness. Dr. Yanni, do you want to start by commenting on this?
Sure. So how to have a timely diagnosis and how to get patient awareness. So some of those things that we discussed during the talk are if the patients have risk factors, metabolic risk factors. So metabolic risk factors such as diabetes, prediabetes, obesity, high blood pressure, sleep apnea, those things should point the physician and the patient to be screened. And screening is now very simple with some blood tests and as simple as an abdominal ultrasound. And once the diagnosis is made, depending on how advanced the disease process is, maybe linked to care to a specialty medicine and see if further risk stratification is needed and if medications are needed for the disease process. So it all starts with knowing what the risk factors are and how which patients to screen that have the risk factors.
Dr. Jamal?
Yeah, I mean, absolutely right. You can it's sort of a multi-tailed tiger, which end do you want to grab first kind of a thing. So yes, we should do risk-based screening, but quite often in practical life, we come across these patients because somebody had an ultrasound done and fat was noticed on the imaging study, and then therefore that workup that Dr. Yanni pointed out would get initiated. In our practice, we've sort of developed a workflow because we see patients because they have abnormal liver tests, so somebody saw fat on the ultrasound imaging, and that initiates that workup to look for presence of fibrosis, either through a FIB-4 score that was mentioned on the presentation, or a FibroSure serologic test. And if they have significant fibrosis, which we grade from 0 to 4, 0 being no fibrosis and 4 being cirrhosis, and if it meets the criteria of fibrosis score of 2 or more, then those patients get referred to the gastroenterologist or hepatologist, whereby then the discussion about lifestyle changes, weight loss, medication therapy, or weight loss surgeries management would then be, those decisions would be made there then. And of course, the prognosis is dependent on how much fibrosis the patient already has, because the outcomes, if you don't intervene, then lead to those cirrhotic patients that Dr. Yanni mentioned, whereby the morbidity and mortality increases significantly. So it's important for us to develop these stop, points whereby you could intervene in a timely manner.
Thank you. I know, Dr. Yanni, you touched on this a lot, but this is an important issue for a lot of patients, weight loss. So one of the question is, what impact GLP-1s are having on patients that have MASH or MASLD? So if you could, both of you, please, if you could expand a little bit on this, because we all unfortunately fortunately or unfortunately, see on TV, even some of the TV anchors and the stars that were relatively overweight have all of a sudden have gotten really small. So we all are wondering if we all should jump on that those medications.
I can start it and Dr. Yanni can add to it. I recall maybe 10 years ago, some little local paper was asking questions about this issue. And I said, well, a tsunami is coming our way of obesity and increasing fibrosis and cirrhosis. It's all coming our way, and all we can do is exercise and diet. So I'm very optimistic in a way, and looking forward to when we have these outcome studies come as time passes by. Right now, we don't have all that information. We do have some tidbits of encouraging information. We know from past experience that if you lose 10% of body weight, that you can actually stop the steatohepatitis and reverse fibrosis. The conventional wisdom used to be that once fibrosis happens or once cirrhosis happens, you cannot reverse it. So, we've known about the fact that, weight loss does increase leads to some regression of fibrosis. And now we have pharmacotherapy that initial results at least are encouraging. And Dr. Yanni probably referred to that New England Journal article from earlier this year that showed not only decrease or stopping of steatohepatitis, but either stability of fibrosis or regression of fibrosis was seen in patients who were on semaglutide. And there's also preliminary, at least, information about patients who have cirrhosis already, and if they are treated by GLP-1, the patients who are not treated have a higher risk of morbidity and mortality and decompensation, which is sort of the slippery slides towards either transplant or death. So there's encouraging signs in terms of intervention with pharmacotherapy leads to decrease in fibrosis. Whether or not this leads to change in outcome in larger population studies, I think that will take time to answer. I'll let Dr. Yanni add to that.
Dr. Yanni?
Very well said. I think I completely agree. There's, like Dr. Jamal said, there's some good information coming out, and more studies are still needed to see whether stability or regression of fibrosis will take place, and how long, whether it will be a long-lasting effect or not. I think there will probably be a role in the future. However, more studies are still needed. We can't really 100% say that at this time until the rest of the studies are available, but I completely agree with Dr. Jamal.
Very good, thank you. While we are on this subject, another question was, what are these medications safe for a liver transplant patient? And what is the effect of this medication on kidney and heart, if we know so far what effects they have had?
Yeah, so for liver transplant patients, we don't have good data for that yet. So they have not been fully studied in patients post-liver transplant. Drug-to-drug interactions with immune suppression, the data there lacks a little bit. So we're still, we don't have good information in that regard. In terms of heart and kidney, I leave that to the experts in those fields. I'm not aware of any bad side effects to the heart and kidney from those medications. Perhaps if patients forget, because it causes such decrease in appetite sometimes, some patients forget to drink water as well. They become dehydrated and whatnot, which can sometimes cause issues with the kidneys, kidney stone and whatnot. But I am by no means an expert in kidney or heart disease, so I would leave that to the experts. I don't know if Dr. Jamal might know a little bit more about it.
No, I haven't seen that. The only recent thing I saw was the increase in neovascular macular degeneration with GLP-1s. I don't know how's that going to pan out, but that's the only other adverse thing that I noticed. Post-transplant patients also have cardiovascular risk factors. I think we have to remember that we're not just treating the liver, we're treating the whole patient. And most of these patients are at higher risk for cardiovascular morbidities and mortalities even before the liver disease would intervene, because liver, as you know, is a little bit more of a forgiving organ compared to the other organs. So especially in post-transplant patients too, I think cardiovascular risk factors are the short-term, at least, morbidity, mortality is higher due to that, not because of recurrent liver disease.
And let's jump on this question. What are the statistics on a transplant patient developing cirrhosis and fatty liver disease again? This is a patient who has had liver transplant because of fatty liver disease and cirrhosis. Are there any statistics?
Yeah, so some studies show that somewhere between 10 and 40% of patients who have had a liver transplant because of fatty liver will redevelop fatty liver again post-transplant. But the fibrosis, patients developing high-grade fibrosis, liver cirrhosis happens in a much smaller number of patients, and it's estimated at about 5 to 10% in 10 years post transplant. So it can happen. So it's very, very important to monitor the diet, be very conscientious of the weight, the types of foods post-transplant, not to get into that situation once more.
Dr. Jamal?
Yeah, no, I totally agree with that. And once again, it's all about modifying those risk factors. Remember, these patients have metabolic disorder, and so focusing on the hypertension and obesity and increasing exercise and improving diet, that's really the answer regarding that. And in addition, if they're on steroids, obviously post-transplant, eventually that will be tapered off too. So those are some of the risk factors for reaccumulation of fat. I think it's about focusing on those risk factors.
Are there any statistical differences between women who develop fatty liver disease and men? Dr. Yanni may have said something and I missed it, but is there any differences between them, men, women?
Yeah, so there are some small studies that show that women may be at a slightly higher risk for fatty liver and have a higher risk of developing liver tumors or liver cancers from fatty liver and fatty liver cirrhosis. It's unclear why that is, whether it's a linkage of care issue, whether it's a body composition issue, but it is those are some of the small studies that have linked that.
Jamal?
I mean, there is some genetic predisposition to this disorder also, but that's not the majority of the patients. And as we know more about those genetic abnormalities, we might have more clarity in terms of demographics. But just purely based on gender, I don't know. It may have to be related to the BMI, age at the diagnoses. Perhaps the age at which diagnosis for women is done is perhaps later than men. Although, having said that, women are more conscientious about following the instructions and trying to lose weight than men are. So outcomes may or may not be different.
Yeah. I'm going to throw another question that you may or may not have answered for. Most women after menopause start putting on weight. So the patients you see, are there more kind of 40 plus years old women? I know there are children, teenagers who are suffering from fatty liver disease. But in general, older women have a tendency after menopause to put on weight. Do you see any difference in that? Either of
Yeah. Fatty liver is becoming more and more prevalent, I think, across all age populations. Because because of diet, because of environmental factors, because of certain genetics. And my experience, most patients that come in, or like a good proportion of patients that come in, like you said, Farah, are above 40. But more and more recently, we are seeing many younger patients, many younger men and women both, coming in with fatty liver. For two reasons, probably. One would be the increased awareness that there's a lot more screening now. So those patients that were young and felt healthy and were felt in those invincible years of teenage and 20s, or doctor is not really a priority and health is not a huge priority for some. But now, because there's some increased awareness, some of those patients are getting into the doctor's offices and getting diagnosed. Whether that's the case, or whether there is, the diet is now possibly poorer, that we're seeing it a lot more in the younger population as well. So that's where I would leave that. But to give exact statistics, it's very, very underestimated, because again, we still need to focus on screening those patients.
Dr. Jamal?
Yeah, no, I don't have anything additional to say on that. You know, it also depends on the demographics also. I think we tend to see a lot more younger population from Hispanic background. And it's not infrequent that I get a referral for somebody who's 65 or 70, the mother has a very high BMI is accompanied by a daughter who's got a BMI just as high. And you can see that progression is going to happen to the next generation. So, you know, so it becomes a two-part conversation then with the patient and the person who's the caregiver.
The next question is, I know obesity is one of the causing effects of NAFLD. I have been skinny all my life. In fact, my family used to make fun of me because I was so skinny, but I have developed fatty liver disease. Why?
Well, that's the lean body MASH. Because remember, this is a metabolic disorder and there's some genetic predispositions to how you metabolize fat and how the free radicals or the bad molecules are handled by the liver. So those are all that perhaps are variables in different people. You know, the example I give to people on that is there are people who smoke and never get lung cancer, and then there are people who smoke but get lung cancer. So the exposure to the risk factors also depends on the host response to that risk factor, and that's different for different people. So it's unfortunate in patients who are lean body, we can't really harass them to lose weight because they're already, 130 pounds or 120 pounds. It makes it difficult, which is why pharmatherapies, such as the new medication that's antifibrotic, is important in that circumstance, I think.
Dr. Yanni?
Yeah, I would completely agree. In those patients with lean body, fatty liver, we just focus more on diet and possibly pharmacologic therapy. It's a matter of what we give the liver to process, if you will, and certain genetic predispositions. So it is possible to have fatty liver with a lean body or not needing to lose much weight.
So the last question is that it says, I realize that fatty liver disease is a global epidemic, and Dr. Yanni, you talked about Mediterranean diet. The question is, does our American diet increase and accelerate the progression of this disease? And what form of diet you're recommending? I assume you would recommend Mediterranean diet.
Yeah, you can call it any diet you want. It doesn't really have to have a name. It mainly focuses on low carbohydrates, hypocaloric diet, and low fat, low saturated fat diet. So that means the type of food matters and the amount of food matters. So if I eat the right type of food, like let's say I love grilled chicken, for example, and I eat an entire chicken every meal, the weight is going to go up, the fatty liver is going to continue happening. So the type of food is important, but the amount of food is just as important. So we want to focus more on lean proteins like chicken, like fish, like plant-based proteins in small quantities at a smaller number of calories than to help with weight loss than what we need in a day, if you will. And that calorie count, not that it's a great way to do it, but it is unfortunately the best way out there to count the number of calories and see how much we intake every day. And that's different for every individual. A marathon runner can handle a lot more calories and still lose weight versus someone who has a sedentary job, for example, or lifestyle, or they're at the computer all day because of work or whatnot. So it's a hit or miss. There's a lot of adjustments that need to be made in terms of how many calories are needed per individual. It's super individualized. But when patients come to the clinic, we give the big headlines. Low fat, low carb. Number of calories smaller than what you need in a day, and split up the meals into 3 or 5 meals so you don't feel like you're starving, and need to eat, feel the need to eat more and more. So I would leave it at that. Whether the American diet has anything to do with it or not, unfortunately, to feed the growing population, we have done a lot of things to the food supply. Not we as in, personally, but like as a society. Things that cattle are fed, preservatives, to keep things on the shelf for longer. There are some small studies to show that the use of preservatives, for example, and pesticides and those things can increase the risk of cancer in general, and not just fatty liver. In fact, if you remember from the talk, Farah, at the conference we were recently in GI, it was one of the reasons that was brought up for increased risk of colon cancer in younger individuals in their 40s now. So there is a possibility that there is a link to the food supply. Do I have a paper to quote you that this is what's happening? No. Do I have a research study to quote you that this is what's happening? No. These are all kind of theories and speculations on why these problems are becoming more prevalent in our society.
Dr. Jamal?
Yeah, just to elaborate on some of those points, partly personal observation, is if you ever travel outside the country, you'll notice that your portions of food you're given are smaller than what we get in any serving in restaurants. So our portions are bigger, number one. Number two, our mobility is less. We tend to travel more by car and less by bicycle or walking. And number three, if you notice in breads, we have a lot of sugar added in our breads. I happened to go to the European meeting last year and I had, bread and croissants or whatever, and they weren't sweet. And you take anything else here, we have a sweet tooth, so we tend to eat a lot more sweet. And the fourth observation is the addition of fructose in a lot of drinks. If you look at the obesity that's gone up over the years, in the 1970s is when we started adding a lot of fructose to drinks. And the obesity tsunami sort of parallels that. It's just an observation. It's not really a study, but I think those are some of the things that I noticed that are different about the American lifestyle.
Yes, we all see that, unfortunately. Well, thank you. This was a fantastic roundtable. I hope everybody has received new and important information. This disease, fatty liver disease, is very important. Some people are diagnosed by the primary doctors of having that, but unfortunately, I have heard the doctors, some doctors tell their patients that it's nothing, just eat less and it will go away. So I want to make sure people understand this is a serious disease and we all need to be on the watch for what we eat and what we do and keep ourselves and our liver mostly healthy. It is important for our audience to know that our presenters are here as volunteer physicians. They care deeply about liver patients and are sharing their expertise and with all of you in support of our efforts in helping liver patients and raising awareness of liver disease. My personal heartfelt appreciation to all of you, all of our doctors, for their kindness and compassion. So thank you, Dr. Yanni, for your excellent presentation. We are honored to have you with us tonight. Thank you, Dr. Jamal. We are proud to have you with us tonight as well. Thank you for participating in our webinars. Thank you to Madrigal Pharmaceuticals for their educational and patient advocacy grants and for supporting us. Please join us on September 20th for the Walk for Your Liver, Los Angeles. This walk is in Santa Monica. It's our annual walks in support of liver patients. During the walk, we will feature many liver patients, and they will share their stories of their liver journey. There will be refreshment for all. Children are welcome and to enjoy face painting, balloon, music, dancing, and everything else. So please visit our website to register. Liver Health Foundation will host a webinar on a rare liver disease called biliary atresia on July 17 from 5:30 to 6:30 p.m. Please join us by visiting our website and signing to attend that webinar. We thank Epson Pharmaceuticals for their support for BA webinar. Most of you know we are all on social media sites everywhere, YouTube, so please join us, visit our site, leave your comments. We announce our events on those social medias. So thank you for joining us this evening for this important webinar. We hope to see you at our upcoming webinar and Walk for Your Liver, Los Angeles. Happy Father's Day to all fathers, stepfathers, grandfathers, and any man who has ever loved, cherished, and raised a child. Be well, stay safe, and thank you, and good night.